Hello, hello, everyone. It's so good to be here with all of you. Awesome. You are already starting before I ask. So, everyone here, please let me know who you are and where you're coming from right now. And honestly, I always wonder what time it is like everywhere around the world. Although I'm really bad at math and time zone differences. I am currently in Madison, Wisconsin in the United States and it's 6 p.m. So, hi, Matt. It's so good to hear from you and see you here. I was hoping you'd be here. And hello, Spence Robert in Houston. Matt, I know you're in England, which, by the way, I did not know you lived there when I was visiting England. I would have loved to met you, but I just have to go back and you have to come here. Hello, Amy from Wisconsin. Fellow Wisconsinite? Is that what we call ourselves here? Let me know because I actually don't know that yet. Hello, Chantel in Canada. It's nice to meet you. And hi, Bree, also in Wisconsin. Okay, so Wisconsin's winning right now in the chat. I don't know if it's winning overall, so let me know where you're from. Oh my gosh, it's midnight in the UK. You are committed. Hello, Sarah from Texas. I just moved to Wisconsin from Texas, so I hope that it's cooling down at all there. I am getting used to not just burning outside every time I go. Hello, Ime or Amy from NYC. Nice to meet you. Awesome. Keep letting me know where you're tuning in from. I love seeing people from all over the world, and it amazes me how committed y'all all are to this space and this community and staying up at odd hours of the night. Hello, Warren from Australia. Wow, really across the world. Okay. All right, so before we get started, I just have a quick few housekeeping things I have to say at the beginning, and then we're going to get into this awesome conversation with all of you. So, first and foremost, this live stream is educational and is not intended to replace therapy. For treatment related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. And the International OCD Foundation is not a crisis hotline. If you are in a crisis or if you are ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the 988 Suicide and Crisis Lifeline by dialing 988. And you can also access online at www.988lifeline.org. We want to create a safe space and be kind and respectful to everyone. At the end of the day, we are all here to support one another. A note that this is being broadcasted on several social media platforms and is being recorded. All right. So, with that out of the way, I'm so excited to get into this conversation with all of you. So, to just briefly introduce myself and to hear more from all of you about yourselves, my name is Uma. I am first and foremost someone who lives with OCD. I have had OCD my whole life, according to my clinicians, and I very much agree. I had the typical story of, unfortunately, being diagnosed far later in life than from when my OCD onset. And I am extremely passionate about advocacy and awareness and raising true awareness about what real OCD is and making sure that people get the treatment and support and community that they so deserve. On top of that, in addition to being an advocate and being someone living with OCD, hugely that informs my work and how I show up in the world. So I am a neuroscientist. I earned my master's in neuroscience earlier this year, and I just started my PhD in neuroscience at the University of Wisconsin-Madison. And I'm going to be continuing to study compulsive behaviors related to OCD and psychedelic treatments in the context of psychiatric disorders, which, if it's not clear, is extremely fueled by my lived experience as someone with OCD too. And I am also a mental health peer specialist. So if you have any questions about peer support, I get that a lot. So I'd love to answer anything that comes up for you. And I do my advocacy in a number of ways. I have a podcast and it called A Chat with Uma. And most importantly, I'm just here to share space with you all. So I just wanted to share some of those parts of my identity so that if you have any questions, you can ask on literally anything. I'm a completely open book. I'm here to talk about recovery and treatment and relapse and neuroscience and research, if that's something you're interested in, and psychedelic work and peer support and just anything that comes to mind at all. So let me go see through your comments. Hello, Nikki in Ireland. Oh my gosh, y'all are amazing. I feel like we need to start doing times where I have to stay up for these. Aw, Sarah, thank you so much. You're so kind. Bree, that would be so cool if you worked at UW. Bree saying that she might work where I am currently a PhD student. Thank you so much, Lola. And yeah, so I guess I was like thinking about what I wanted to share on here and how I wanted to kind of kick off the conversation. And I guess what comes to mind is that I'm just going to talk about where I am right in this moment with my OCD and my recovery. And I think the reason I feel called to share this right now is because I think a question I get a lot in my advocacy on social media, especially for my podcast, and anytime I'm on these live streams, is really talking about feeling like I'm not, people don't feel like they're recovered enough, or they sometimes are comparing themselves to people on these live streams or advocates like us at the IOCDF and kind of wishing that they were in a better place. And I think because of that, I'm really passionate about honestly just normalizing the experience of recovery being a journey and having ups and downs and not having a linear path to recovery while also living a beautiful, big life and living more toward our values than ever before. And the reason I say that is because there's an assumption sometimes that, me being on here, me doing the work that I do, that I'm just like living merrily and happily and like my OCD is all but gone. And the reality is I actually have restarted OCD treatment. And I guess it's a little complicated to call it restarted. For me, I was in ERP treatment with two really awesome providers who were able to treat me for my OCD and my comorbid PTSD, but due to various reasons out of my control, which happens in the real world, I had to stop seeing both of them after a period of time because they left the practices that they were at and my insurance no longer covered it. And so I went a period of time without active ERP treatment, which was, it was hard, but also I was fortunate enough to have learned so much in treatment to be able to get by and improve and recover with so many of the tools and resources that were given to me that are available with this community. And really just my life grew so much in that process. And I think it's so important to highlight how much recovery changed my life and how much life improved in those years. And also, I still needed and need treatment. And I want to normalize that can be possible and that might be part of someone's path. So I moved to Wisconsin. I got my new health insurance and I had the privilege of getting access to a new provider who I've been working with for the last, I think, like 3 weeks, a few times a week. And, I was really, really scared of starting active ERP again and, working with a third person for OCD treatment. I think, well, I've worked with many, many therapists. I think many of our stories include working with people who did not know how to treat OCD. So this is my third OCD therapist, to be clear. There's a lot of fear around starting again and feeling kind of like an imposter in a way of like, I'm going back to ERP. Like there's shame I'm feeling for whatever reason, even though I shouldn't, feel shame. And my values don't lead me to feel shame and I wouldn't shame anyone else. But because of the standards sometimes of feeling like you go through treatment and you're just better, for me, just working on accepting and having compassion, like true compassion for myself of where I was at and acceptance of the non-linearity of my journey has been astronomical. And also just trusting the process and learning to trust a new provider for the third time was going to be pretty difficult, or I thought it would be. And it's actually been great so far. And it's been hard. And there's been a lot of work in self compassion and just becoming aware of a lot of mental compulsions in particular. And I guess I'm sharing all of this again to just normalize that our journeys can look different and also that it's okay and multiple things can be true. And I'm just so grateful that I was able to still access treatment and that it's helping me grow and evolve in even more beautiful ways. And it just humbles me and reminds me of why I'm here and why I do what I do. So I'm reading some of your comments right now. Matt, you are just so kind. Thank you so much for all of your upliftment and all the love that you're sharing with me. And I just want everyone in the comments to see that, like, the way Matt is speaking to me is how, like, this applies to everyone, not just me. And everybody is incredible and everyone is worthy of treatment and of recovery. And I'm just sharing that love right back to you. And I also want to highlight his second comment. I've just started peer support training as I'm so passionate helping the community. It's absolutely my calling, and there's no better rewarding feeling, empowering and lifting someone up in their journey as everyone can absolutely find the light at the end of the tunnel. Matt, you are you are so right, and people who get to experience your peer support are so lucky. People in the chat who get to read your comments are so lucky. I'm so lucky to know you and to just experience your light. And you're so right. Like, there's so much pain and hurt and confusion that we can go through with our journey, and being able to channel that into purpose if it feels aligned for us, and to support other people going through that and help them feel not alone and have our journey as an example for them is so, so empowering. And I hope that anyone who feels called to this steps into it. We need more peer supporters in the world. So thank you, Matt. 608 from Chantel. I love this because I am always comparing myself to everyone that is in recovery. I feel that so deeply. And thank you for saying that. Thank you for validating what I just shared, because it's difficult to get on a live stream in front of everybody as someone who's an IOCDF advocate, be like, hello, I am starting ERP treatment again. I am still in therapy. And that should not be hard to say. And no one's made me feel like that's hard to say. It's this internalized dialogue we have of, like, comparing ourselves to what we perceive in other people. And also, we never know what other people are going through when we're all human, and it is not a weakness, or there's not something wrong with us if we still need support, and we deserve that support, and everyone's journey looks different. So thank you for that. And just know that you're so valid in wherever you are too. Amy, thank you so much for your support and validation as well. And just know that you're not alone too. Hello, Nagin from Iran. It's nice to see you. I hope that you're not up too late, but also thank you for being up too late. So I see a question at 612 from candid saying, hi, do you think OCD and generalized anxiety is a part of, I'm guessing, evolutionary process or a result of a genetic predisposition? Any solid evidence? And I will preface this again by saying that I am not a medical professional. I am a neuroscientist. I am continuing to study neuroscience, but I'm not a doctor, at least the kind of doctor that prescribes things. But that being said, to my understanding from the research, in terms of genetic predisposition, there is evidence of a higher genetic likelihood of people having OCD if they have first degree relatives or more that have it. But the sad and complicated answer at this point is we don't know why people have OCD. We don't know exactly what causes it. And I know you don't want to hear this, but at this point, it's a confluence of many different factors, genetically, environmentally, different triggers that can occur. And we are working really hard to pinpoint some commonalities. But at this point, in terms of something called GWASs, which is gene-wide association studies, there exists far better data for other psychiatric disorders because, or illnesses or whatever it is you want to call it. In this case of research, we're calling it psychiatric illnesses or psychiatric disorders. For other illnesses like depression and I believe schizophrenia and even bipolar disorder, there have been far more concrete ways to find commonalities in genes and genetic dispositions to disorders, because there's been far more research with far bigger powered sample sizes to find those commonalities. And with OCD right now, we're working on it, but they're just not there right now. So we hope to have more people who can participate in this research, that we hope to have more funding for this research. And that's what all of us in the research world are working so hard towards. So that's my answer on genetic predisposition. And then in terms of, do I think OCD or generalized anxiety is part of an evolutionary process? I mean, in terms of the experience of vigilance or the fear or anxiety, and I'm not talking about the pathological amount or a disorder, like the actual feelings of them, of course, I think we can all intuitively figure out that like there is a purpose to fear, there is a purpose to vigilance. But when it crosses over to being pathological and longstanding and not reciprocal or appropriate for the circumstances, of course, that's when it becomes or is a disorder. And so, yeah, any feeling really, for the most part, can be traced to having a evolutionary reason that we have it, but a disorder is kind of the opposite of that. It's like when that becomes something that completely doesn't make sense and does not serve us. So that's my answer to that. I have a question and I love these questions, by the way. Thank you for giving me some of that for the research questions. I love talking about all of it. Eva at 612 says, "Hi, Uma. I would really love to hear if you know how effective psilocybin is with OCD. Also, what do you feel is the next best option when you cannot afford OCD treatment?" So 2 questions in there. First, psilocybin. Again, speaking from the research synthesis perspective, of course, also as someone who has OCD and is very interested in this topic, and as someone who has done research on and has worked on research with other people, but I'm not speaking from any sort of recommendation or, all the caveats, I hope. So we are in very preliminary phases with psychedelic research in general, especially for OCD, especially for psilocybin with OCD. Thus far, preliminary results in terms of very first findings of research are finding that in some people, there is a novel amount of recovery or, effect of the psilocybin and assisted therapy for people. But that is so far away from being a clinical recommendation or something that is a first line or just a treatment for OCD. So I need people to hear that. Like, research is it is such a process. And I know like that annoys people sometimes. I get a lot of comments and a lot of messages from my podcast, like when I share research updates or, have interviews with people doing research. People in the community often get upset with me and say like, we need to go, you all need to go faster. You need to do this research now. This is important. And like, I promise you, as someone with OCD, I know. And good quality research needs years to systematically do this in a safe, effective way and test it in different populations and different dosages and different circumstances against placebo controls, and also just assessing safety overall and long-term effects of anything. So I can tell you that psilocybin and OCD, and what I'm basing this on, if you want to look up, current trials going on and see if, you want to learn more or if it's a good fit for you to engage with said clinical trials, they're happening, to my knowledge right now, at Yale University with Dr. Chris Pittenger and Dr. Ben Kelmendi, as well as Dr. Francisco Moreno at the University of Arizona, and I believe also at Imperial College London. I can't remember the researcher's name, but you can find it. There are trials, but that is not a clinical recommendation. And there's also very specific populations that they're looking at right now, because comorbid disorders make things more complicated. And basically, we're in the infancy of this research. It's promising, it's novel, it's having effects that are very hopeful, but still very, very, very early in the research. The next question from Eva was, what do I feel is the next best option when you cannot afford OCD treatment? That's an incredibly important question. I personally find that the IOCDF's resources, specifically things with the self-help resources on the IOCDF's website, are incredibly, incredibly supportive and helpful. I think they've done an amazing job creating an evidence-informed, I won't say evidence-based necessarily, evidence-informed resources of how to employ the principles of exposure and response prevention of ERP in people's lives. And it's a really complicated, nuanced thing to say because, of course, like ideally one works with a therapist, but accessibility is a very real issue. So that is what I would say maybe is the next best thing. And also, there is an incredible clinician named Kimberly Quinlan. I'm sure you know her. She is your anxiety toolkit on social media and has a podcast. She has created a very equitable and affordable resource called ERP School for those who cannot afford treatment that basically takes people through to my understanding, takes people through the different iterative steps of like how one would explore ERP with a therapist and then kind of do it on their own. And I've heard amazing things about it. I think Kimberly's amazing. So that might be a resource you want to check out as well. But overall, I think the question really just raises an issue of what we are all working toward and that I'm incredibly passionate about, especially of accessibility to care and the discrepancy of accessibility, whether it is due to finances or cultural barriers and stigma and having access to insurance and having our basic needs met. And that's so, so important. And I wish there was a clear-cut answer, but people are trying. Beautiful people are creating resources. So that's what I'll say on that. Spence Roberts says, is psilocybin preferred to LSD for OCD research/treatment? To my knowledge, that is the first compound or one of the first compounds that are being tested. Oh, and I forgot to mention Johns Hopkins also has a trial, if that's closer to some people, for psilocybin with OCD. They're just starting. I don't know that there's a preference necessarily. It's more so the ability to study certain compounds given current FDA regulations and licenses. And also, at the end of the day, a lot of these studies are being done, and there's different phases for trials because of, assessing safety, then assessing dosage, and assessing efficacy and long-term things. These trials start from oftentimes like doing a deep dive on the anecdotes out in the world and, treatments that people are engaging in outside of the United States or, in different, perhaps even illicit ways. And so I think there's been a lot of reporting in the past before and during the early days of the psychedelic renaissance of psilocybin in particular, which is why I think that was kind of the first place that researchers went. There could be more to that story that I'm not, thinking of or knowing right now. I can say that that's not the only psychedelic or psychoplastogenic compound that's being looked at. Ketamine is also being looked at, as well as MDMA, though those are also in their infancy, and everything I said about psilocybin applies to those as well. So as more things get published, I'm sure they'll be shared here on the IOCDF and also at conferences. In fact, there was an amazing panel that I had the privilege of facilitating and being on psychedelics and OCD at the last IOCDF conference with some of the major researchers in this field, all of whom I recommend you go check out their work if you're interested, which is Dr. Carolyn Rodriguez at Stanford, Dr. Chris Pittenger at Yale, Dr. Terrence Ching at Yale, and Dr. Jamila Hokanson at Yale. So you can learn a lot more about their work by Googling them as well. Matt's comment at 613. Thank you, Uma, for all that you do for the community. It's just some nice things to me. Thank you so much, Matt, again. I'm so grateful you're here. And yay, I'm so excited that you're going to the conference. Oh my gosh, Florida, like going to Disney or Universal. Harry Potter land is where it's at. Sarah H says, sharing in case it helps anyone at all. The NoCD app is an amazing place to get help. Yes. Absolutely. The NoCD app, as well as their support groups. I know that they have support groups and they have cost-effective ways of getting treatment. It's incredibly important work they're doing, and I would highly recommend checking them out. As far as I know, there are payment plans and ways to work with insurance if possible, so it's a great resource as well. Amy says, it's definitely comorbidity. I'm a therapist and I have OCD plus GAD. And first of all, thank you for all that you do as a therapist. And Also, I also have both OCD and GAD, and that's something that's extremely common. And yet, given that they're distinctive disorders, that comorbidity is so interesting and is something I'm very hopeful to study in my PhD in terms of looking at their neurobiological basis and kind of figuring out where they converge, where they differ, and, you know, why that can show up in so many people. But also, some people's OCD don't even have the anxiety component. So it's fascinating. Spence Robert says, is peyote slash mescaline ruled out because many with OCD are emetophobic? That's a good question. I think it's, first of all, I don't think it's ruled out. I just don't think that that's where the research is happening right now. And as someone in the psychedelic research space, I could say that, like, in general, peyote and mescaline are not compounds that are like the most popular to be studied at this very moment. I think in terms of just accessibility and systemization of how it's synthesized or produced or um, obtained in research. So I think I don't know that it's being ruled out for any indication necessarily. I think like the field is just booming right now, and we're kind of going deep with certain compounds. And I'm sure we're going to go wide eventually when we have more resources and there's more robust data to go off of. Amy says researchers need people to volunteer for studies. There often aren't enough volunteers. Thank you, Amy, for saying this. That is so important. And I think part of what I'm so passionate about raising awareness for is the fact that research is so dependent on people like you and me participating. And of course, there are barriers to that. It requires time from the volunteer to be able to donate. It requires access to even institutions around us that are doing research to be able to, go participate in. It requires like a knowing in the first place of research being a thing, which very much excludes many historically excluded populations, minoritized populations, because they just aren't aware of research being a thing in the first place. I know growing up, like, there was no way I was ever going to end up in a research study, though I very much should be. And as an adult, I'm trying to compensate for that. But that's because I grew up in an immigrant household, and we had no idea of mental health or any sort of idea of what psychiatric illness was, let alone participating in research. So yes, it is so important for us to participate. And I think there's a mentality sometimes when people see like researchers soliciting volunteers that, oh, like someone else can do that. That's fine. But if everyone thinks that someone else can do it, like it's very difficult to get populations. And the reason we need so many people is because, we have to exclude many people for certain reasons. And so we end up with very small populations. So I think, yeah, we just need to do a better job of outreach. And I really hope to bridge that gap so people feel more inspired to engage with research across the board. Let's see. Matt says, I have a question with ketamine. Is ketamine being further researched for more trials to become a new form of medication? Yes, it is being researched thoroughly. And as far as I know, the current, well, let me try to summarize. And it's very, very complicated, of course. And there's a lot of papers and a lot of different findings. But effectively, to my understanding, ketamine has been looked at for quite a while because it is not a psychedelic. It's not a classic psychedelic for anyone here who's new to kind of hearing about this term. It doesn't interact with the same receptors that classic psychedelics do, yet at certain dosages have similar cognitive and kind of effects on our state of being acutely and in the long term, which is why ketamine is also kind of lumped into that category by most people. But ketamine has been a compound that's been around for decades. It's extremely accessible. It's used as an anesthetic, and it's, incredibly cheap, at least from the perspective of producing it. Getting it's another story as a medication. But anyway, it's extremely accessible. So people have been, and researchers have been looking at ketamine as a possible intervention for many severe psychiatric disorders, especially and including major depressive disorder, which there's lots of exciting research about this, it being another standard of treatment. But for OCD, it's also been looked at for quite a while. And initially, sometimes the results were kind of mixed or kind of disappointing because of what they realized was the populations that people were looking at ketamine in were people who were also on other medications and had other comorbid diagnoses. And so it was kind of hard to assess if ketamine was directly helping OCD because of all of those variable factors. So more recently, Dr. Carolyn Rodriguez at Stanford and her research group have been doing placebo-controlled ketamine infusion studies in OCD patients and a very thoroughly screened out population for people who are not on medications and are not do not have comorbid depression, and I think other comorbid disorders as well. Don't quote me on that. And it's going to be published soon. And this is still just published data. This is not like the new standard of treatment or like, a recommendation for treatment. This is just the next step in the process, but they have very positive and exciting results for people in that very clean population. But this is very important to highlight on this live stream because we hear, novel, significant, which means like positive, effectively results, and we get very excited. But we have to look at the fact that that's, again, like I said, a very clean population of people. The vast majority of us are not like clean in that way. And in order to generalize very limited findings to larger populations, there need to be so many more studies done and just an overall assessment of how this plays out in the real world, for lack of a better term. So again, as a researcher, I wish I could like give you shorter answers, but I'm always going to give you the long, nuanced answer, even though that is pretty short. But yes, ketamine is still being further researched in more trials to become a new form of treatment or medication. And I should also add that like it's being looked at just like other psychedelics to be at this point used as like a very like immediate response treatment, which is quite novel for OCD. Typically medications taken every day, or there's interventions that take quite a while to go through. And the whole, huge motivation in the field for looking at psychedelics is because we're looking for treatments that can provide relief to people who need it now. And as great as it is to have relief, perhaps in 6 months or 6 weeks or 3 months or, however long, like if we can find a way to help those who need help now, that would be great. So that's something interesting about ketamine treatment, or at least it's motivating that. But yes, work's being done. There's a lot more work to be done, though. Great question. Bree says, do you have any strategies you use for managing physical health conditions and OCD? I've had more chronic pain lately, and I'm figuring out what works for me. Amazing question. And I should say that Bree is probably asking this question because she's familiar with my story. And for those who aren't, briefly, I do live with OCD and other psychiatric conditions, and I am also a spoonie. Which means I live with chronic illnesses. I have had several autoimmune diseases that I've lived with for most of my life. I also live with cancer. I was diagnosed with cancer when I was 22. I'm 27 now, and I live with a metastatic form, which I'm okay. I'm in cancer suppression mode, but all of that to say, I live with comorbid disabilities and chronic illnesses, and I live with chronic pain. So that's where Bree's question's coming from. And first of all, I'm sorry that you're dealing with this. It's hard enough to deal with OCD and to deal with not just all of these disorders together or individually, but to have them come together and overlap can be excruciating. It can be heartbreaking, and I'm sorry that you're dealing with it. For me, the biggest strategy I have found to manage any and all of this is honestly acceptance and the true sense of the word self-compassion, which I know we talk about on these streams and in the OCD community like all the time. But for me, it's taken me many years to wrap my head around the term self-compassion. And I'm still working on it. But for me, acceptance and self-compassion are kind of the only ways I've been able to navigate it, because I have not found a strategy that like helps make it better, like other than managing my physical health flares and like managing my OCD. And especially when my OCD latches on to my health conditions and, relapse and, the hardship of the fact that I've, lived through very life-threatening things, and my OCD has a lot of fertile ground to latch onto in terms of like, what if they come back, and what if, this mole is cancer, like the number of biopsies I have, which were valid, but also like extremely debilitating. it's a lot. And so rather than being able to like actually manage the pain or manage um, the flares and the debilitation that comes from all of this, because I don't really have control over that other than, my lifestyle and medication and getting the best care I need. Like, because I don't have control, the best I can do is accept that they're there and not add like 50 layers of resistance and trying to fix it and figure it out, because it's so easy to find myself, at least, in a cycle of like, if I just do this thing right, if I just get the right treatment, if I just keep looking and looking and trying, I can get it and I can figure it out and I can make it better. And there's a line, right? Like, of course, with physical health conditions or, any condition really, like there is something on us as patients to advocate for ourselves and to, be resourced and try to the best of our ability, seek out, treatments and what's best for us, especially when sometimes we fall through the cracks. But I was there was so much burden added to my plate of feeling like that was my job and that's all I could do. And the answer to my pain and the answer to my debilitation was to keep trying to figure it out. And that just sucked life away from me. I wasn't living life anymore. I was just consumed by my next symptom and what was coming next and being afraid of what was coming next. And like, just accepting that it is what it is. It doesn't mean we need to like it. It doesn't mean that we're like giving up on wanting to get better. It doesn't mean that recovery is not going to happen anymore. It just means that we're not putting so much effort into trying to manage and fix it and control it and just living. And honestly, the amount of exhaustion that was lifted from me from just working on acceptance and allowance and feeling truly for myself rather than berating myself and trying to fix it, it gave me more of my life back than I could have ever imagined. So that is the best advice. And I wish I had something better. I wish I had like a concrete strategy of like, do this and then do this, and then both will get better. But all I can say is I think everyone, whether they have these conditions or not, like could use some more acceptance and self-compassion in their lives. I don't think that's something we're taught as functioning human citizens on this earth. So I hope that helps at all. Reading some more of your comments. Sarah H says, they send you a vial so you can send in a saliva sample. They're trying to study the genetics of OCD. I don't know what study you're referring to, but I'm sure if people Google it, they can find it. That is so important and such an awesome way to contribute to research from your own home. So thank you so much for sharing that. I appreciate it, Sarah. And I've got to do that too. Let's see. Dusty says, thank you for today's stream. Thank you for being here. And thank you for allowing yourself the gift of community and to be seen and heard. I think everybody here and everyone who takes the time to tune into these and to engage with the community and the content, I think that's just a beautiful example of self-compassion and self-love, because you're giving yourself the gift of connection and of being supported. I know that for me, I resisted this for a long time because I felt like I didn't belong and I didn't deserve to hear these things because of everything my OCD said about not feeling like I actually have it. I mean, how many of us our OCD has told us that we don't have OCD, right? So to be here anyway toward your values and to allow yourself to experience this, I'm just so proud of all of you, and it inspires me to continue to do so. Matt at 628. I have a very important question though, Uma. What came first, the chicken or the egg? Oh my gosh, this is my favorite question. The reason Matt asked this question, for anyone who has no idea what we're talking about, is I have a podcast called A Chat with Uma. Matt has said some very nice things in the chat. Thank you so much for that. So on my podcast, I have a list of rapid fire questions at the end. I say rapid fire in quotes because if anyone knows me, they know that I am not a rapid fire anything. I talk and talk and talk as I have today, which makes it fine for a live stream. But anyway, I ask all of my guests what came first in their opinion, the chicken or the egg. And spoiler alert, for anyone who's listening or who would be on the podcast, I'm not looking for a right or wrong answer. I just love hearing how people answer it because they usually have a very long, descriptive response to that question. And I feel like that's just very telling of where they're at. And so, how would I answer that question, Matt? I've never been asked it. Okay. My answer is I don't know, and that's okay. And I don't care because chickens and eggs are awesome. That's my answer today. I'll probably have a more like philosophical, deep answer at some point. If someone ever interviews me on my own show, I guess I'll have a better answer. But that's what I've got today. And thanks for asking. Amy says at 6:31, Orchard OCD has a database that researchers from all over the world use. Please add their data for researchers to share. Yes, absolutely, 100%. I will also add that the researchers at Cambridge or the University of Cambridge and other researchers involved with Orchard OCD are doing such amazing work. And I have an episode on my podcast with OCD Science on Instagram. It's Dr. Ana Maria de Souza, and she's talking all about the latest research on GABA and glutamate and OCD and their Orchard OCD repository and how that has informed their research. So that episode is awesome, and she shares some really cool research. Also, it's an amazing example of how people participating in research makes such a huge difference in this field, and we've discovered some things that we never would have had people not worked with Orchard OCD. So do that, people. Let's see. Chicken and eggs are awesome. Amy's answer to Matt, does it matter? That's telling of you, Amy. I love that answer. Oh my gosh, a lot of people are answering this question. Okay, Sarah H. clarified on the past comment on the genetics saying it's the Baylor Forge study, Forge. And that, thank you so much for highlighting that. If anyone wants to participate, please Google the Baylor Forge study. I know Baylor has an OCD research program that's doing amazing work. So thank you for highlighting them. I know they'll appreciate it. All researchers appreciate it because we do not get enough attention. Let's see. Bree said, thanks. The chronic illness special interest group has been helpful. Yes, that SIG is amazing. It's run by chronically.courageous on Instagram. The humans that run that is amazing. And I highly recommend everyone here in general check out the IOCDF special interest groups. There are so many groups for different populations of people with comorbid conditions or lived experience or identities. And I think we all know that OCD does not exist in a vacuum. If it's a part of our life experience, it interacts with so many other parts of our life experience, like we just talked about with Bree earlier with chronic illness being an example. So definitely check out the SIGs. Let's see. Keep sending in your questions. I'm loving answering them. And awesome. I think the IOCDF sent links to their special illness group, or I keep saying special illness groups, special interest groups. Okay. Matt says, self-compassion has helped me so much in my journey and incorporating mindfulness. They've been absolute game changers, especially with value-driven ERP. I think that's so important to talk about because I think there's been a lot of conversation and dialogue recently about ERP being misunderstood and kind of being portrayed as something that's extremely horrible and painful and something that like people need to force themselves to do and how that's not ERP at all. And it needs a rebrand and it needs like a a representation of what it actually is, which includes values-driven living and being able to work with things like mindfulness and self-compassion to really be able to engage with ERP in a healthy, values-driven, motivational way. I think it's been interesting for me. This is really like helping me think about my own journey with ERP. And like I said earlier in the stream, I did ERP and other things, but mostly ERP with two different therapists. And then I had about, it was over a year of a break to be able to find a new provider who was able to work specifically with me with my OCD and comorbid PTSD. So with ERP and conjunctive PTSD treatments. And in doing ERP, like, I guess I've been always doing ERP, but in being an active OCD ERP treatment with a new provider, I've realized like the difference in the way I've been approaching it. Like in that point in my recovery, as I was like still trying to learn about, real OCD and about ERP, like it just felt very, and to no fault of anyone's, it was really just, I suppose, the way I was taught it and the way I interpreted it. It was like, I have to do this. This is so hard. Like this is torture, like, but this is treatment and I won't get better if I don't do it. And I have to like white knuckle and grit my teeth. And like in doing this ERP now in, I guess a more educated way, or I've just had more time. I'm older, many, many white hairs to show that. It's been so wild experiencing that and realizing that I'm doing it to continue to reclaim my life. And I'm doing this because I want to. And yes, it is extremely hard and nothing is going to take away from the difficulty. And that's so important to validate. And also, hard doesn't have to mean like always painful and excruciating and, you know, even feeling like torturous, at least in the moment of like putting yourself through that. It's not a thing that I'm putting myself through. It's an experience that I am allowing myself to have. And I think that's also very evident in terms of like consenting to the experience and feeling like I want to do it and um, being participatory in my own treatment. I think that's so important. And I think people need reminders of sometimes. Like, we are going into treatment as the patient or as the client or as whatever you want to call it. And I think with OCD in particular, but generally with any illness, particularly psychiatric illnesses, I think it's easy to lose trust in ourselves and feel like because we're the person with the disorder that we're the ones with the broken brains, quote unquote, or we're the ones who are dysfunctional. And so like we can't listen to ourselves and we have to listen to whatever everyone's telling us and we just have to do what they say and they know what's best. And that mentality has gotten me in a lot of situations with therapists and providers who have not done their job to help me or that have not listened to me or that have not treated me correctly. And even when they are treating me correctly, like having that dynamic of I am broken, there's something wrong with me, and like they know everything and I have no right to say or feel anyway, other than like fully bowing down and just agreeing with them. That just took away my autonomy and I think fed into my own narrative of like, this is supposed to be so hard and I hate this and I'm doing it and I'm gritting my teeth and white knuckling and whatnot. But being able to feel like I'm a human and yes, I am struggling and I have a disorder or I have disorders and this is hard and my brain does, scream at me and, doesn't work with me in certain ways. And also, I'm still allowed to have autonomy and I'm still a human who can make choices and I can agree to these things. I can consent and my perspective is valid too. I think engaging with ERP that way has been game changing for me. And it honestly just brings me some sadness that I wish I had experienced that or realized that earlier on. And yet that's just recovery. That's just learning. And I'm grateful to have it at least now. So I just want to say that for anyone going through treatment right now who might feel that way or might be earlier in the process and could use maybe some of that empowerment or support to remember that they have a say in treatment and that they are so valid. That tangent came out of where? I don't know, but my last name's Chatterjee. So, all right. Looking more for your awesome comments. Oh my gosh, they are so many. Hello, Erica. Thank you so much for being here. Sarah H says, do we know the schedule for the OCD conference on October 21st to 22nd? It's my first, and I want to make sure I schedule time for self-care. Is it all day, both days? So, Sarah, first of all, I really applaud you for thinking about your self-care. That is so, so important. And I think the beauty of the online conference, the in-person conference is amazing. And I think the unique beauty of the online conference is number one, there is flexibility and, there are replays, at least there were last year. So I hope that there are this year too, so that if you cannot attend everything, which is not possible to attend everything. So already take that pressure off yourself for anyone attending conferences. Like part of my job as a researcher is to attend conferences. So I'm just constantly learning optimization tools on how to like survive a conference. But anyway, make sure you schedule time for self-care. You cannot go to everything. There will be multiple sessions at one time, or multiple presentations during one session that you'll want to go to. And it's okay that you miss the other ones. It just is what it is. And you'll get what you need and you'll learn something valuable wherever you go. And also, more concretely, yes, I think the schedule is published. I think there's still edits that are being made or things that are being added to the schedule. And stay tuned. I have an announcement for the conference myself soon, in a way that I'm going to be involved. So I'm really excited. I don't know if I can share it yet. So basically attend the conference. I'll be there. And yeah, I think it's all day. I don't think it's like, literally like from the crack of dawn to dusk, but it is a large amount of time each day. So yes, schedule self-care time, and also remember there will likely be recordings. Brennan, if you know the answer to that, let me know, because I'm just guessing based on last year. Let's see. Amy said rebranding ERP part 2 is tomorrow. Oh my gosh. I went on this tangent and I didn't even know that. Okay, we are all clearly just in sync in this community. So definitely tune in to that tomorrow. I'm sure it's going to be amazing. Hello, Stephanie from Philadelphia. Thank you for joining us. Stephanie asks a question at 6:46. How does OCD affect the brain? That is a great question, Stephanie, and that is something that we are continuing to work on and figure out. And the short answer is we don't know, but we have some ideas and we have some evidence in certain models. And when I say models, I mean that one would think when they hear neuroscientists that we are studying the brains of humans, but the reality is there are many, many limitations to being able to study the literal brains of humans, because I don't think anyone wants us to go in their brain and like turn on and off their neurons and turn on circuits and things like that. So to be able to get really specific and granular and kind of take what we can see with human imaging data, which is pretty non-specific but still leads us to some some ideas, we then have to go to things like animal models and computational models and stem cells and many of the things which I've done in my career and will continue to do, because we have to approach neuroscience from different angles. All of that to say that there are not concrete full answers to that question of how OCD affects the brain, but we can pretty definitively say that there are certain circuits and when I say circuits, I mean different parts of the brain that communicate with each other that then cause further communication with other parts. And it's just this loop, effectively, if you want to think of it, different people having a chain reaction. That's kind of what a circuit is. There are different circuits involved in compulsive behavior and obsessions and kind of putting together OCD that are pretty distinct and unique from other disorders. So we are looking to fully understand what that means from both a brain parts talking to each other perspective, as well as the different neurotransmitters involved to facilitate that communication, as well as the expression of genes and receptors that influence how and why the brain develops that way and how and why the brain communicates with each other. And I can tell you some of the brain regions that we are particularly interested in the field involved, generally speaking, there's something called the corticostriatal thalamic cortical loop, if you want to Google that. And that's basically talking about the cortex, the striatum, the thalamus, and there's other parts as well that are being looked at heavily. Of course, I think everyone thinks of and talks about the amygdala, which, side note, the amygdala is not actually one structure. I mean, it's one, overall thing, but there's like anywhere from 6 to 12, maybe more subnuclei. So in my last research position, I was studying the central nucleus of the amygdala, which is like one of many parts of the amygdala. So that's a fun fact for anyone who's interested in the amygdala. But there's the amygdala. People are looking at the hippocampus. There's many different parts of the brain that people are looking at, to not just look at individually like, oh, this part of the brain is like different in people with OCD. It's like not just different, but how is it communicating differently and causing a chain reaction of things that ultimately lead to a hypervigilance to threat, an inability or lack of ability to be flexible in behavior, and compulsive repetitive behaviors, which is pretty classic of compulsion. So very long-winded answer, because that's research. But thank you for asking. That clearly brings me alive to answer. Matt's comment at 646, really well said, Uma. When we want to do an exposure of what OCD is taken away from us that we love is very powerful in recovery. You have such a way with words, Matt. Thank you for inspiring everybody. Eva says at 648, one more question. Do you know if EMDR helps OCD? That is a very good question. I get that question all the time. And to my knowledge, at this point, from a research perspective, EMDR is not an evidence based or gold standard treatment for OCD. There are people who have reported sometimes that EMDR for the indications that EMDR exists, which primarily is for post-traumatic stress disorder or PTSD, has somehow or sometimes helped them to be able to then engage with their exposure and response prevention better for OCD, but EMDR itself is not an established treatment for OCD. That's not to say that there aren't individuals out there who might have tried EMDR for OCD that might have helped, but that's not something that's established. And the reason that this is an important question to ask is because there are a number of individuals who have tried EMDR for OCD, and it's not only not helped, but has made it worse. And I can also, from an completely anecdotal experience, I can tell you that I engaged in EMDR for quite a long time for post-traumatic stress disorder, not for OCD, but for me, EMDR did not work because of my undiagnosed and untreated and very, very severe OCD that was coming up during EMDR and was, in fact, making my OCD worse as a result of trying to experience EMDR. That's not to say that would happen to everybody, but I do really share that a lot because I just want people to know that they should look for at least having providers on both sides if they are looking for EMDR for PTSD, and they have an OCD therapist to make sure that those providers are communicating with each other, or are in sync, and are both thinking that it's a good idea to try, and that they're making sure that their EMDR for PTSD is informed and is OCD informed. So yeah, to sum it up, EMDR is not something that's established to be a treatment for OCD. If people engage with it for other conditions and also have OCD, I would highly encourage them to just make sure they're doing it in a very safe, evidence-based manner. Let's see. Spence Robert says, Stephanie at 655. Stephanie, I was just thinking about how OCD reminds me of an autoimmune disorder. For OCD, it's the survival/error detection circuitry doing far too much. That is definitely a huge piece of it. So you are totally right. And I think that, what the beautiful thing about neuroscience and the different approaches we have in it is that we take the human experience and like the human experience of OCD, and we're able to kind of look at which brain regions are associated with the dysfunction going on. So for example, you were talking about the survival part of OCD and like feeling like everything is a threat and being extra vigilant to things that don't necessarily warrant it, which is generally associated with the cortex and the thalamus, and error detection as well with that and the amygdala, and then the repetitive behaviors, feeling like we have to do things and not being able to inhibit them as much, which is generally, and I'm saying this generally because it's very nuanced, but it's related to the striatum. So very much so, agreed with you. Amy says, we don't know which came first, brain changes or OCD. Some of the changes are also seen in people who do drumming but don't have OCD. And you are very much right about that, in that we don't know which came first. We're definitely trying to find more causal pathways, and that's part of the opportunity and struggle and limitations of research right now, which is why it takes so long, and which is why we never ever say in research that we know something or that this is a fact or that this has been proven, because we just don't know, and we are piecing information together and we're learning more about what we don't know. That's in sum what is research. So that's very true. And also to your point of comparing people who do drumming to those who have OCD and seeing similar patterns, that speaks at large to the limitations of brain scans. And I'll use this last minute I have to do a PSA that brain scans do not diagnose medical conditions. If anyone's telling you that, they're incorrect. They're used to assess brain activity in certain ways, have many limitations, and that's why you don't go to a doctor and get a brain scan to be diagnosed with a psychiatric illness. So that's an example of the limitations of brain scans. It could tell you that you have OCD maybe, or it could tell you that you are drumming. So I'm glad you brought this up. It's funny, but it's also like talking about science communication and making sure we're all accurate. So, okay, we are just hitting the end of the hour. So, my gosh, I'm out of breath. I was like trying to answer all these questions, and I am just so grateful to all of you for showing up and coming with so many engaging questions, especially the research questions, because I know that you all are just so interested in learning more about ourselves and each other. And that's why I'm here. That's why I do what I do. And I really, really appreciate you spending this hour with me and sharing all the empowerment with each other in the comments. Just this community never ceases to amaze me. I'm so grateful for all of you, and you all continue to motivate me to continue in my recovery and healing. So just sending all of the love and hope and care in the world to all of you. And just to close out with some final announcements, the online OCD conference registration is now open. Visit iocdf.org/online OCDcon to register. This year's online OCD conference will feature 2 days of virtual programming for the entire OCD and related disorders community. Also, walks are taking place across the country. Visit iocdf.org/walk to find a walk near you. I'll be at the Oconomo Walk, Wisconsin Walk in 2 weeks. The online proposal system for online OCD camp is now open. If you're interested in presenting programming for this special event, head to iocdf.org/camp. Subscribe to our YouTube channel and be sure to follow us on Facebook, Twitter, and Instagram. This live stream is one of many. You can see the entire schedule of feature streams at iocdf.org/peace of mind. You can also view recordings of past live streams as well as watch our hosts answer your pre-submitted questions. OCD Mailbag on IOCDF's YouTube channel, youtube.com/IOCDF. Remember to like and subscribe to get notified when live streams are scheduled. And if you need resources, please visit iocdf.org. And finally, some upcoming live streams coming up tomorrow, Wednesday, September 27th at 12 p.m. will be a lunch and learn. And then Tuesday, October 3rd at 7 p.m. will be a town hall. So thank you again for your time and for being here, and have a beautiful rest of your night, everyone.